The United Hospital Fund is a health services research and philanthropic organization located in New York City that tries to shape positive change in the healthcare system, focusing on points of leverage like insurance, the Medicaid program in New York State, family caregivers, and most recently the innovations in healthcare services. Fundamentally, I'm a hospital administrator. I worked for 25 years at Montefiore Medical Center as the vice president for planning, doing program development there. So I'm a delivery system guy. Well, innovations, you can either go broad or deep. And my specific area of interest has been in primary care and primary care transformation to a model that's called the medical home or advanced primary care, which we think has a tremendous potential for changing and improving the way healthcare is delivered and the way it's received. What is it? To begin, why are people doing this? They're doing it because the existing model of primary care has migrated in a direction which is unsatisfying for patients and for providers. I think so. I think there's two different pieces to it, and everybody tends to focus on the economics, that primary care physicians are underpaid, which by comparison to most other specialists they are. But it's also a question of job satisfaction. There is a burnout in primary care where you're on this conveyor belt that has to move very fast in order to be able to make enough income to pay for the overhead of the practice, as well as to generate an income for the physician. And they're not satisfied by it. The payers are beginning to understand better that core competency around the management of patients with chronic disease really makes a difference in terms of patient outcomes, quality, and also in terms of utilization and cost. You can avoid hospitalizations and ED visits because somebody's available to the patient, somebody they trust. The well patients, you want to keep them well. You want to stay on a preventive schedule. You want to make sure you're dealing with their minor ailments in an effective way, and make sure that they're calling you when they think they might have something that could turn into something. For the acutely ill, you've got a different set of problems. They're often handed off to other providers. Somebody has to coordinate those referrals, get the information back, turn it into a different kind of a care plan. And for hospitalizations, it's all about transitions, emergency room visits. The doctors have to know about those things, and they have to be able to follow up with the patient after the ED visit. And they often don't know about it and therefore are unable to follow up effectively in a timely fashion. The new program in New York is called Advanced Primary Care, which takes a model which has been around for 5 or 6 years now, the patient-centered medical home and the various variants of it that have the core competencies of the medical home in processes that have to change, different ways of scheduling visits, different ways of handling patients, different ways of managing their care, and adds to that measurement and outcomes reporting, so that the primary care physicians are now, in a more systematic fashion, going to be tracking some of the key markers of quality of care, some of the key markers of patient satisfaction, and some of the key markers of cost and utilization. The people that have the big change to do, though, are the primary care physicians. They've got a business model that's tuned to deal with fee-for-service, CPT code-driven care, and that's how they pay the rent. That's how they pay the bills. They have a big change to make because it means changing the way your work flows, how a patient is managed from the moment they walk in the door till they are discharged and after that, the kind of follow-on care. Here's where electronic medical records are actually very important and really enabling, because what EMRs do is they give you the ability not just to deal with individual patients, but to begin to group patients, to risk stratify your patients so that you can identify these are the very sick patients, and these are the ones that you really need to focus on. We're seeing that in New York, that the small practices are having a lot more trouble getting into the medical home model into maintaining it, because the medical home model costs more. It's more staff, it's more functions, it's stuff that isn't currently being paid for in the visit-based payment system. You're following up with patients over the phone. You're developing portals where you can respond to the questions and needs of patients offline. There's really one argument that is the most important in convincing payers, that this will save you money, this will improve the quality of care that your patient or your members are getting in primary care, and that long term it will be a really sensible investment for you. This is the return on investment question. You see changes in quality within a year or two. You can really come up with measurable changes. The management of patients with hypertension or with diabetes or some of the other chronic illnesses, the high-cost patients, you can begin to see that pretty quickly. The turnaround for reductions in ED visits and hospitalizations, that's where everybody tends to focus. And they say, show me that the medical home reduces costs of care and utilization of services. I think that's probably 2 to 3 years out. That's been the experience of most of the places that have been doing it in New York. And we're starting to see some really positive, demonstrable, p-values type outcomes that are really strong cases for the medical.